Hello, good morning, ladies and gentlemen. I'm Dr. Woo Kyung-jung. I'm from Samsung Medical Center, Korea. I'm very pleasure to be invited in the Congress in the VSRNM, and I'm very happy in here. Is Dana, very beautiful city. Actually, today's topic is enhancing HCC diagnosis and the treatment with liver-specific contrast agent. The content of my talk is my content is overlapped with plenary lecture by Professor Jungmin Lee. You previously heard, and actually some overlapped. Anyway, my talk content is first I'd like to introduce the liver-specific contrast agent, gadolinium EOB DTPA, and sonazoid for the contrast-enhanced ultrasound, and then I'd like to discuss about the role of hepatobiliary phase of gadolinium EOB DTPA and Cooper phase of sonazoid. Oh. I'm sorry. Yeah. Actually, the HCC is although the many antiviral drug for the hepatitis B and C is developed and the main patient is treated by them, but the HCC is still the fourth most common cancer death worldwide, and its risk factor is liver cirrhosis, hepatitis B and C, and alcohol consumption and so on. So it is very difficult to treat, and the 5-year survival rate is still low, and approximately less than 15%. And if the risk factor is not treated, the recurrence is frequently occurs. So early diagnosis of HCC is very essential and very important. First, I'd like to introduce about Primobist, gadolinium EOB DTPA. Actually, the gadolinium BOPTA and gadolinium EOB DTPA is the liver-specific, hepatocyte-specific contrast agent. It is introduced 10 years ago. And especially, gadolinium EOB DTPA is 50% of the injected contrast media excreted via bile duct. Other contrast agent is mostly excreted via kidneys. So it is enhanced hepatocyte itself. And after 20 minutes, depending on the hepatic function, but it is enabled to obtain the hepatobiliary phase, HBP. Actually, the mechanism of the hepatobiliary phase is depend on the OATP1 and the MRP2 receptor. Actually, normal hepatocyte, so OATP1 is act to influx of the contrast media in the hepatocyte, and the MRP2 receptor is excreted via bile duct. But most of HCC is a decreased OATP receptor, so it is blocked by it makes contrast media influx is blocked into the cell, and so it's a hepatoma cell is a defect of the contrast media. So it's a background hepatocyte is well enhanced, and the hepatoma is a defect. So we can easily detect the hepatic tumor. This is a good example of the HCC. The first one is of non-contrast and arterial and portal venous and delayed phase. And you can see arterial phase is well enhanced. No. Okay. Oh, sorry. Yeah. Okay. The arterial phase shows a good well enhancement of the mass in the right liver, hepatome of right liver, and the portal venous phase is a washout, and the last one is hepatobiliary phase. The hepatobiliary phase shows more clearly depict the mass on the right hepatic lobe. So and the next one is another tumor. It's a right liver is also well enhancement on arterial phase, but the hepatobiliary phase did not show the washout. It's different. What do you know this tumor? Actually, this tumor is focal nodular hyperplasia. It's not HCC. Hepatocyte-specific contrast agent shows can discriminate these different types of tumor. The HCC is HCC is a hyper enhancement on arterial phase and washout on portal venous phase. And you can see a defect on the hepatobiliary phase because of the OATP receptor is not function, so the contrast media is not influenced into the tumor. But focal nodal hyperplasia consists of the normal hepatocyte, so it can get a contrast media through a OATP receptor, so it is enhanced on the hepatobiliary phase. So it looks it's iso intense on tumor, looks like a normal hepatoparenchyma. Next, I'd like to another type of liver contrast agent for the ultrasound is Sonajoid. Actually, so we are Sonajoid. Our country is the Sonajoid is we use the Sonajoid is about for 10 years. Yeah. The introduction of the contrast-enhanced ultrasound. The first generation ultrasound contrast agent is a Levovis. Very old agent. It's about very fancy, very good idea of the. It is very good contrast agent, but it's very difficult to handling and preparing, and examination is very difficult, so it is not usually used. But second generation ultrasound is Sonoview and Sonajoid is very easy to prepare and perform the examinations for radiologists. Use the hepatic reticular endothelial system. It means the Cooper cell. Cooper cell is in the hepatic sinusoid. Its role is phagocytosis in the sinusoid, so it is taken up the foreign body or something like that. So actually, it's a microbubble. Sonajoid is also, they recognize the Sonajoid is as a foreign body, so Cooper cell is uptake. So Cooper actually is the Cooper. Second figure shows it's the red one is a Cooper cell, and you can see a very tiny green one in the end, like arrows. It's a very tiny particle. Is a Sonajoid. It means the Cooper cell is taken up the Sonajoid in the Sonajoid in the hepatic sinusoid. So we can use the Hooper page imaging. It means Hooper page imaging is actually many hepatic tumor is Cooper cell is depleted. The tumor is replaced the Cooper cell, normal sinusoid. So tumor is defect, and the normal parenchyma is uptake the Sonajoid. So it's well enhanced. Anyway, we make the Hooper page imaging. After injection, we wait 10 minutes after injection, and we can obtain the Cooper page. So Cooper page is increased sensitivity on malignant hepatic tumor. It's like a hepatobiliary phase of gadolinium UV DTPA. Yes, okay. Left side is the arterial phase of Sonajoid, and right one is the Cooper phase on the it's HCC. Actually, Sonajoid is type of the combined agent. It means the most of the contrast enhanced ultrasound is a blood pool imaging. Just it is in the just blood vessel, But it's Sonajoid is a blood vessel, and it is taken up by Cooper cell. So it's a combined imaging, combined agent. Anyway, the first one is 1 minute delay imaging. The message is a subtle washout on the. Oh, yep. Oh, actually, so yeah, but it's a Cooper page image. You can see clearly mass on the right liver, and this mass is also hepatobiliary phase is very clearly depicted. So Cooper page imaging is enhanced lesion to liver contrast. This is the imaging protocol of Sonajoid CUS. First, you are injection of the contrast media. It looks like a CT on MRI, but so we can obtain the arterial phase in the real time. So we can obtain the video clip. So after injection, and we are looking at the mass, and if the contrast media is appeared in the mass, we start on record a video clip. So we record the full arterial phase, and just actually 60-second image is very important. It's between injection and to a 1 minute image is very important. So we are recording the image, and then we are alternatively capture the images via 3 minutes or 5 minutes, and then after 10 minutes we can obtain the Cooper phase image. This table is a comparison of the sonazoid CUS and the EOB DTPA. So left side is Cooper phase, and the right side is hepatic biliary phase. Actually, it's very similar role, but the characteristics is very different. So Cooper phase, actually, so Cooper phase on the sonazoid CUS is on the defect from the hypervascular, well-differentiated HCC and the moderately differentiated and poorly differentiated HCC is hypoechoic, but dysplastic nodule is isoechoic. So we can describe the HCC and dysplastic nodule. But hepatic biliary phase on the gadolinium EOB DTPA is sometimes some dysplastic nodules on the also can show the iso-intense on the hepatic biliary phase. So we cannot discriminate the high-grade dysplastic nodule and early HCC. So it has a risk of the decreased specificity on the for the HCC on hepatic biliary phase of EOB MRI. And next topic is the role of hepatic biliary phase on the gadolinium EOB DTPA. Actually, so in most HCCs, the unpaired artery is progressively developed in the dysplastic nodule, and decreased portal flow in the nodule it makes the typical imaging finding of the HCC. It's arterial enhancement and washout. And conventional MRI is actually shows this typical imaging and but this imaging criteria is very high specificity, but the sensitivity is not much. It's not enough. So gadolinium EOB you can use gadolinium EOB DTPA. You can more detect. You can detect more the hepatic nodules, very small HCCs. So the increased sensitivity. So and according to the many previous studies, it maintained the specificity of the tumor. And then the gadolinium EOB DTPA can also used for the predicting a prognosis of HCC. Actually, so we know the many findings of the poor prognostic factors such as large tumor size and multiplicity, and the absence of the encapsulation, and poor cellular differentiation, and vascular invasion such as macro tumor thrombosis and microvascular invasions. Actually, vascular invasion we divided we classified to a macrovascular and macrovascular. Macrovascular invasion is also tumor thrombosis, and we can observe on radiology study, conventional radiology study in the CT and MRI and the contrast enhanced ultrasound. So if we found the macrovascular invasion, it is contraindication of liver transplantation. Sometimes liver resection is not recommended because this finding is a very good, very important finding of the early recurrence after resection or liver transplantation. Actually, microvascular invasion we cannot see the microvascular invasion on conventional imaging. Actually, the microvascular invasion is a very small thrombus in the peritumoral portal vein, but it's very small, so we cannot see microthrombi on the conventional imaging. But we can find the secondary findings, such as thrombus makes perfusion difference, such as peritumoral enhancement or peritumoral hypointensity or something like that. So anyway, Anyway, the microvascular invasion is associated with aggressive tumor biology, especially such as epithelial mesenchymal transition. EMT is a very is characterized by a loss of cell adhesion protein, and it is increased cell migration and extracellular degradation. So, if the tumor has the EMT, so it is more tumor is circulating in the blood, and it can easy to metastasis on different side. Actually, microvascular invasion is as I mentioned, it's very associated with patient's prognosis. So if we are able to predict the presence of microvascular invasion in the HCC before treatment, it's very useful about the prognosis after the treatment, and we can choose the best treatment option for the patient. The key finding is the microvascular invasion on the hepatobiliary phase is peritumoral hypointensity, as well as the tumor irregular tumor boundary. Actually, it is a good predictor of microvascular invasion, and hypointensity areas, like it's the last image. You can see a tumor and around the tumor in the very irregular hypointense area. Actually, it's not it's a tumor boundary, but it's a microsthrombi makes the perfusion difference around the tumor, so it's a secondary finding of the microvascular invasion. Anyway, so if we can find the hypointensity area around the tumor, actually we mentioned about it is possible of the microvascular invasion, and according to my study, is very high specificity. Actually, the sensitivity is very low because many microvascular invasion makes this like this. But if you can see this finding, is that the specificity is very high. Yeah. Actually, the last topic is the role of the Cooper phage on the sonazoid CUS. Actually, the CUS is somewhat different from CT and MRI because the contrast enhanced ultrasound, it's a microbubble, it's a contrast agent for the CUS is just in the blood vessel. So it's a blood pool agent. So it's not diffusion around the extravascular area. So its characteristics is quite different from a CT and MRI contrast agent. So the imaging finding is also different from CT and MRI. But the arterial phage hyperenhancement is the same. It's a very key characteristics of HCC, like CT and MRI. And we can obtain the real-time imaging during the examination, so it's very advantageous over the CT and MRI. Actually, CT and MRI we cannot see a full arterial phage on the CT and MRI, but CUS is possible. And washout is quite different. Actually, the washout of HCC is late. Late means over than 60 seconds after injection, and mild degree of washout is the characteristics of HCC. It means many intrahepatic cholangiocarcinoma actually is not HCC, is a very early washout and marked washout. Marked washout means a very clear defect, clear black tumor on the. Anyway, so it's very different. So actually, so coprophage. What is the role of coprophage? This example shows the difference of the two tumors. The HCC shows the arterial enhancement, and after 1 minute, is not we cannot find any tumor in the round in the circle, but after 4 minutes, we can see a mild washout in the tumor, and coprophage is more clearly defect on the tumor. And in contrast, in intrahepatic cholangiocarcinoma, it's a rim-like enhancement, and it's a very early washout on the 40 seconds. It's 40 seconds, and the coprophage is very clearly defect on the mass. So actually, the coprophage cannot differentiate the two tumors, but it's it's a vascular phage. It's a 1 and 2 minutes delay images can differentiate the two tumor. Nevertheless, the Cooper page is can use the HCC diagnosis in when the many HCC is not show some HCC is not shows the washout on the vascular phase, even a 2 minutes delay. So it's we cannot find, it's just arterial enhancement but did not wash out. But Cooper page is wash out. We can consider that the tumor is HCC. Because the HCC washout of HCC is very late, very mild. So examiner cannot recognize the tumor washout. So it's a Cooper page is help to diagnosis that for the such tumors. Anyway, we developed and we published the guidelines for the diagnostic guideline for HCC diagnosis using a sonazoid contrast enhanced recently, so this year. This is an example of the hepatocellular carcinoma. It's, the male patient is the years of 67 years, and non-B, and heavy alcoholics. The typical finding of HCC on MRI, you can see arterial enhancement and washout and clear defect on the hepatobiliary phase. So actually, it's the same figure. So on the when the previous shows, and there's an arterial phase enhancement and no washout on 1 minute and mild washout, and the 4 pages of clear defect. On pathology, it's the upper one is the normal parenchyma and is the surrounding parenchyma, and the lower one is the tumor. Actually, CD68 means is uptake on the Cooper cell. So the density of the Cooper cell is very high, but tumor is depletion of Cooper cell. It is well shows the characteristics of the Cooper page imaging. Actually, the HCC on Cooper page, several studies about the HCC on Cooper page. This study shows the hypervascular, well-differentiated HCC is It's not the hypo Cooper page washout is could indicate the HCC. It means all hypointense lesion is HCC. It's a hypovascular HCC and hypervascular HCC. But it's a hypovascular well-differentiated HCC is about 88% is isoechoic. So it's somewhat tricky to differentiate to a well-differentiated HCC, the isoechoic and also hypoechoic. So different studies showed also so well-differentiated HCC is half and half is isoechoic and hypoechoic. But moderate differentiated HCC is the most of the tumor is hypoechoic, and This is a different tumor. It's a focal nodal hyperplasia. It's a benign tumor. It's a male patient with a 37-year-old, and you can see a hypervascular mass on the found incidentally, and there is no risk factor of the malignancy. So you can see a good enhancement on the arterial phase on MRI, and hepatobiliary phase shows where persistent enhancement. Is because it's not washed out. And in the sonazoid image, it's a well enhancement and not washed out, even Cooper page. Actually, it represents the tumor have a normal Cooper cell, normal hepatocyte, and it is not replaced by the tumor cell. Actually, the pathology imaging also shows a similar density of the Cooper cell on the surrounding parenchyma and the tumor. And in conclusion, this is the last study of last slide of my talk. Is liver-specific contrast agent is gadolinium UV DTPA for MRI and the sonazoid for the contrast-enhanced ultrasound. And it is offered to you to specific phases of imaging, hepatobiliary phase of gadolinium UV DTPA and Cooper phase imaging of sonazoid CUS. And the role of this contrast agent is the first one is an accurate diagnosis of HCC. It can increase sensitivity with maintaining specificity, and the hepatobiliary phase is predicts the bad prognosis after treatment, It predicts microvascular invasion, and it is useful for the differentiate benign hypervascular region, such as focal nodular hyperplasia. Thank you for your kind attention.